It's nice to have options when your patients present with therapeutic challenges. In this video, we'll discuss the anatomy and approaches for two sets of nerve blocks that reduce the risk of phrenic nerve blockade when used to provide analgesia following shoulder surgery. There's no question that interscaling brachial plexus block is the gold standard block for shoulder surgery. If awake shoulder surgery is your goal, then this is what you're after. It's that complete. But there's a cost. We know that even modest volumes of local anesthetic spill over the anterior scaling muscle and cause phrenic nerve block and hemidiaphragmatic paresis. Here's where we do the interscaling block, and you can see the proximity to the phrenic nerve. In fact, any block of the brachial plexus done above the clavicle will have a non-zero rate of phrenic nerve blockade. Now, in most patients, this is not an issue, but in a subset, those with severe obesity or pulmonary disease, that 27% reduction in their pulmonary mechanics could spell trouble in the form of respiratory embarrassment. And so it would be nice to have an alternative, perhaps something more distal along the plexus. So let's consider the innervation of the shoulder joint. There are 5 principal nerves: the suprascapular nerve, the axillary nerve, the upper and lower subscapular nerves, a small branch of the musculocutaneous nerve, and the articular branch of the lateral pectoral nerve. If we wanted to try to get as many of these as we could, in effect try to reproduce the interscaling block without the side effects, we have essentially 2 options. The first is to perform a selective suprascapular nerve block in combination with an infraclavicular brachial plexus block. Here's why that makes sense. Here's our brachial plexus. You can see the suprascapular nerve comes off the superior trunk early, and for that reason, you can't just do a distal brachial plexus block alone. You'll miss this important nerve. The other 4 nerves, axillary, lateral pectoral, musculocutaneous, and the subscapular nerves, take off at or just beyond the level of the cords. So an infraclavicular brachial plexus block, done at the level of the cords, will effectively knock out all 4 of these in one go. Importantly, it's virtually unheard of for the phrenic nerve to be blocked when performing an infraclavicular brachial plexus block. It's just too far away to be a concern. So that's one solution: get the suprascapular nerve by itself and then perform the infraclavicular brachial plexus block. The second option is to just perform the selective blocks of the suprascapular and the axillary nerves. Now, this ignores those other 3, but it turns out that the lion's share of nerve supply to the shoulder originates from these 2 nerves. So while the block is not as complete, it's very good. And as we'll see in a moment, these 2 blocks are easy and convenient techniques to perform, so the relative value is high. We do both of these sitting up. A linear probe is placed over the supraspinatus fossa, just anterior to the spine of the scapula. The beam is directed down into the chest. With this orientation, we can visualize the bright white bone of the supraspinatus fossa, the trapezius and supraspinatus muscles on top, and a little dip or notch as we move the probe laterally towards the acromion. This dip is the spinoglenoid notch, and the suprascapular nerve and vessels travel through this on their way to supplying the scapula and shoulder joint. Our goal is to advance a needle in plane from medial to lateral and contact the bone just medial to the notch. It's not necessary to advance a needle into the notch. It only puts you at risk for hematoma and/or nerve injury. Okay, so here's what this looks like. We've got the bright scapula at the bottom of the image and the 2 muscles above that, and you can see the dip or notch at the lateral edge of the screen. We often don't see the nerve or vessels here, but that's okay. The needle is advanced and the aim is to contact bone just medial to the notch. 10 mils here will lift the supraspinatus muscle up and layer out in the fossa, blocking the nerve effectively. A common misconception is that this notch is the suprascapular notch. That structure is more anterior, and you definitely don't want to place a needle through there, as the chest wall is immediately anterior to that. What complicates this is that many novices aim the beam too anteriorly, resulting in an unsatisfactory image. Tilting the beam so it's quite steep will give you an ideal image of sloping bone and the spinoglenoid notch. We then move the probe so it rests on the posterior humerus, just distal to the humeral head, in the parasagittal orientation in order to do the axillary nerve block. You should be able to visualize the humerus, the oval-shaped teres minor muscle, the deltoid muscle superficial to that, and a small hyperechoic triangle of connective tissue where the 2 muscles meet. This contains the posterior circumflex humeral artery and the axillary nerve. The technique involves advancing a needle in plane from the cephalad aspect until it rests in or near this triangle, and depositing the local anesthetic here. If you can't see the nerve, again, that's okay. It's there. Okay, so here we are. We again see the humerus at the bottom, teres minor and deltoid muscles on top. Nestled into the corner where teres and deltoid meet is the fascial compartment containing the posterior circumflex humeral artery and the axillary nerve. The needle is advanced from the cephalad aspect. You do want to avoid contacting the artery, and it's often prudent to just put the local beneath that fascial triangle rather than try to breach it. 10 mils of local anesthetic is more than adequate to block the axillary nerve here. Suprascapular nerve block is effective enough that it comes close to providing the same quality of analgesia as the gold standard interscalene brachial plexus block. This systematic review found that it was non-inferior except for early time points in the recovery room. This is good news for our sick pulmonary patients who may not fly with half their diaphragm knocked out, but still deserve excellent pain control. And we see here that while analgesia is comparable, patients do not have dyspnea with suprascapular and axillary nerve blocks, whereas 1/5 of those receiving interscalene do report some breathlessness. And here are some tips for these Phrenic-sparing nerve blocks. First, the selective suprascapular and axillary blocks don't require high volumes. 10 mils each gets you excellent effect. Number 2, you may hear of the anterior approach to the suprascapular nerve block. We do this essentially where the supraclavicular brachial plexus block takes place. The most lateral hypoechoic structure under the omohyoid muscle is the suprascapular nerve, and it can be easily targeted. The problem with this is that it's above the clavicle and still more or less part of the brachial plexus, so the risk for phrenic nerve block is not zero. If you really need to spare the phrenic, choose the posterior approach. And finally, the supraspinatus fossa easily accommodates a catheter, and continuous techniques can be done here for those patients that need longer lasting analgesia.